Now our patient has an NG or OG tube, and we round on this patient every day. So every day we round, we need to think of the following. Do we still need the tube or OG tube? If not, please remove it as soon as there is no indications. So that's the first thing. The second thing, if there was an x-ray done, a chest x-ray done, especially critically ill patients where most of them they have daily x-ray, check placement on chest x-ray if done. Don't forget that. Third thing, ask the nurse, is it still functioning? Is it functioning or not? Are they having difficulty with using it or not? Is it flushing okay or not? This is a question, but the nurse usually will tell you if it's still functioning and or they having problem with that or not. Also, examine patient nostril or mouth if they having OG tube. If it's NG tube or OG tube, examine them, make sure there is no new onset wounds or some signs of necrosis, and this can happen. The longer the tube stays, the more the risk, the higher the risk it can happen. So that's why we need to remove them as soon as possible. Also, don't forget, very important, every day examine their abdomen and make sure it's soft and no signs of rigidity or distension, because we've seen cases of perforation, gastric perforation that happened from NG or OG tube. So that's why it's important to see this. Also, part of reviewing the chest x-ray, if there is a chest x-ray, especially in ICU, those critically ill patients, usually they have daily x-ray, check for any air, free air under diaphragm, because that could be a sign of perforated viscous. And believe it or not, radiologists sometimes can miss that. So you need to pay attention to that. And of course, very important, examine the patient. Now, part of the general care, you don't do it and you don't have to know much about it, but the nurse usually flush the tube every Q4 to 6 hours with water, make sure it's patent and keep patency. Also, avoid, and the nurse will tell you, giving any medications that known to clog the tube. Avoid any medication that will clog the tube. Again, nurses usually know this medication, a famous one, familiar or known one, PPIs. Because in order to give medication through the NG or OG tube, you need to crush it. And so some of these medication are known to clog. Again, if the nurse tells you, oh, this is very difficult to do and it will clog the tube, then try to switch it to something else or use IV. Also, avoid extended release medication completely. Actually, when you order these through the tube, the pharmacy will call you because, hey, we cannot do it. Why? Because we cannot crush it. Because the whole point of extended release, you don't need to crush it, and that all that material will now become instant release. It has to slowly be released into the body. So you cannot use anything with SR, XR, ER. Those are the terms that we use for extended release medications. The other problem that we may encounter, and remember, before I forget, if there is malpositioning on the x-ray, you need to adjust the tube. Please please tell the nurse, do not use it. Let's advance it or retract it, whatever you need to do, and then confirm it with another x-ray, and then tell them you can use it. Now, also bleeding. So an NG tube or OG tube it's in already, and sometimes the nurse will tell you, hey, I'm getting coffee ground material coming through the tube, or blood coming through the tube. And this is mainly for those NG tubes or OG tube connected to low intermittent suction, because this is the most common suction, because there is continuous suction or intermittent suction, there is low or high intermittent suction. But the most common one we use is low intermittent suction if we need. I've never used high intermittent suction or continuous high continuous suction or low continuous suctions. This is the most common one. That's why do not use suction if not needed, and DC suction as soon as you don't need it. Many times I come and round on the patients and I see the tube is connected to suction. Why? Oh, since we placed it, the doctor said to connect it to suction for no good reason. The patient doesn't have obstruction, doesn't have any reason to have suction. So please, if the suction is not needed, discontinue that. And if it's needed, as soon as you don't need it, DC that. Somebody with small bowel obstruction, now he's clinically better, there is minimal output coming from the tube, then DC that immediately, because suction irritates the mucosa more and can cause bleed. But now you're getting this, the nurse calling you with this or this, treat this as acute upper GI bleed until proven otherwise. What you do, stop using it, make the patient stop using the tube. You can make the patient NPO, start IV PPI if not used already, and call GI and ask them about, most likely they will scope this patient, they will do upper endoscopy, but ask them, do we remove the tube, which I prefer, or if we can salvage and keep the tube. If you in doubt, you're not able to reach them, I would recommend to remove the tube. But if you can't, call GI, ask them about that. So these are the main things, and remember, once you don't need the tube, you can remove it. If at any point you have signs of acute abdominal rigidity or air under the diaphragm, immediately call general surgery and remove the tube as well. So that's how we should round on a patient that has an NG or OG tube every day.